Today we will learn coronary dominance. For understanding coronary dominance, first we have to know the arterial supply of the heart. Heart is supplied by the right coronary artery and the left coronary artery. Right coronary artery arises from the right anterior aortic sinus. In the right side, there are two aortic sinuses, right anterior and the right posterior. Posterior is non-coronary sinus, that no coronary artery is emerging out from the right posterior. And left coronary artery rises from left aortic sinus. On the left side, only one aortic sinus. Aortic sinuses are three. Aortic sinus, that means the space just above the aortic valve. There are three semilunar valves in the aorta, in the commencement of aorta. Right anterior, right posterior, and the left. So, the right coronary artery arises from the right anterior aortic sinus, and then it gives nodal artery as a nodal artery. Okay, arterial nodal artery in 60% of the cases, and then give the right marginal artery. We supply the right margin of the heart, and then it continues as posteriorly and going to anastomose with the left coronary artery. Okay, here is one anastomosis. Before anastomosing with the left coronary artery, right coronary artery give one more branch, very important, that is the posterior descending artery. It descends and it is on the posterior aspect, so posterior descending artery. Now come to the left coronary artery. It arises from the left aortic sinus, and now first it gives left anterior descending or left anterior descending or anterior interventricular artery or widow artery. All are same. Now the left coronary artery, after giving this branch, named as left circumflex artery. Left circumflex artery on the posterior aspect anastomose with the right coronary artery. This branch, which is given by the left coronary artery, that is the left anterior descending or LAD, come posteriorly and anastomosing with the posterior descending artery. Okay, these two descending arteries are very important. Left anterior descending, it supplies the anterior 2/3 of the interventricular septum. Where is the posterior descending? It supplies posterior 1/3 of the interventricular septum, as well as the AV node. Very important, that posterior descending supplies the AV node as well as the inferior and the posterior surface of the left ventricle. This is right ventricle and this is left ventricle. Here, this is left ventricle. Posterior descending supply the inferior and the posterior surface of left ventricle as well. AV node as well as the posterior 1/3 of the interventricular septum. And from where it is arising? Normally what happens? It is arising, as we are seeing here in this model, that the posterior descending artery is emerging out from the right coronary artery. Right coronary artery. So this decides the dominance, that in 80% of the cases, posterior descending artery is the branch of right coronary artery, and we can say in another way that in 80% there is right coronary dominance. as the posterior descending is the branch of right coronary artery, so right coronary dominance. But in 10% of cases, this posterior descending artery is not the branch of right coronary artery. It is the branch of left coronary artery. Left coronary artery, it gives the posterior descending artery. And it anastomoses with its own branch. This will be absent in that case in 10%. The posterior descending, which is emerging out from the right coronary, now in 10% it is arising from the left coronary and anastomosing with its own branch, that is the left anterior descending. Okay. This type of condition is called the left dominance in 10%. It is very dangerous. Left dominance is very dangerous because here both the branches, that is the anterior descending and the posterior descending, both are the branches of left coronary artery. Normally the left coronary artery is suffering with the myocardial infarction. The atheroma is lodged in the left anterior descending or widow artery. As this is the left anterior descending is the branch of left coronary, and in 10% it is also giving the posterior descending. So it is anastomosing with its own. There is no collateral circulation. So there will be complete blockage. There will be no blood is going to the AV node, no blood is going to the interventricular, left ventricle. Everything will be hampered. The blood supply, the necrosed. Okay, ischemic region will be there everywhere. So in 10% who are left dominance, or you can say left super dominance, because the left coronary artery is giving the both anterior descending and the posterior descending. So this condition is also known as left super dominance, and it is very dangerous and very clinically significant, and it can be memorized by CAMPA. CAMPA cola, the CAMPA, CMPA, C for coronary artery bypass grafting. For the same reason, there is no collateral circulation, as both are the branches of the same mother, that is the left coronary artery. Okay, so it will be dangerous in CAMPA, that is the coronary artery bypass grafting, M for myocardial infarction, P for percutaneous coronary intervention, and A for aortic valve replacement surgery. In all these cases, the left dominance is very dangerous, or left super dominance. Now in 10%, and again this is the third type, the codominance. 10% is the codominance, in which the posterior descending is the branch of both right coronary as well as the left coronary. Both are giving branch. This is present, and also this is present. This case is not dangerous because there is collateral circulations are there. If one branch is going to be hampered, other is going to supply that area. So that is not dangerous. Dangerous is what? The left dominance is dangerous, and only present in the 10% of the cases. So this is all about the coronary dominance. Thank you.